haven't got much idea on that bite on bite. I'm just guessing, I guess. So I don't want to comment on something I didn't know. But certainly in the multidisciplinary meeting, as you rightly pointed out, when we look at it, is it something endoscopically resectable or neoadjuvant chemotherapy or going for this? It all depends on the aggressiveness of the disease. Majority of our decisions on upper GI MDT depends on either neoadjuvant to reduce the tumor load, and then we go into surgical one. So depending on the PET response and all those things. So my involvement for endoscopy, basically for those patients is involved is to see sometimes you have like PET negative diseases. So in those cases, we just go back and reassure they're doing the surgery, because some of them, if they had complication, they say, do you really need to go to surgery? That's a question, medico-legally we are being asked. That's a question. From the point of neoadjuvant chemotherapy followed by surgery, the question is to make sure that if there is a problems with the initial diagnosis, that's what we do. But honestly speaking, I don't want to comment on something I didn't know.
This is something which is still very evolving. I think bite-on-bite biopsies is something which is not routinely done at most of our centers, including our hospital as well. And another thing to keep in mind is many patients post neoadjuvant chemo-RT, they have a very bad stenosis, and a complete pass is not possible sometimes because of the strictures. Those patients also underwent immediate surgery. So any endoscopic no pass in the protocol, in which that you cannot pass the point of the stricture, you cannot obviously assess the disease status beyond that point. So it was assumed that they had some residual disease, and then they also underwent a esophagectomy. So this is something which is very interesting. I would request any of our senior surgical colleagues to comment what is your interpretation of the SANO trial, and do you think that this is something which could be offered to especially our patients are very different from the trial designed patients, and intensive surveillance is something which not many of them would be keen for. But in those patients who achieve a clinical complete response, at least this is an option that can be given to them, because this is now proven in a large multicentric phase 3 trial. So you would not really be harming them, provided that they are on very close regular surveillance.
One point I would like to add on is the gentleman rightly said, stricturing upper GIs. A lot of centers don't have the pediatric gastroscopes, I believe. Is that right? And they would like to assess the extent of the tumor. As you rightly said, the MRI esophageal imaging is evolving. I agree with that. So pediatric gastroscope is important. Number two, pediatric biopsies are not useful for diagnosing malignancy. So you only use that to see the extent of the disease by stricturing diseases.
So bite-on-bite biopsies are also called well biopsies. So we usually do it, I don't know the protocol followed in the SANO trial, but we do it for lesions for which like mucosa is normal. So we want to take out the mucosa out and then expose something which is beyond the mucosa, so that deeper tissue is taken biopsied. It is called deep well biopsy or bite-on biopsy. I don't know the protocol in this.
Your point is very well. Actually, recently I had a patient who had early satiety. But when I did the endoscopy, she's definitely malnourished, came from another services. So she's got non-distensibility of the stomach. So the bite-on-bite biopsy, what you're talking about, is a mucosal lift, is linitis plastica. In those scenarios, they definitely EUS is indicated, and I sent her for PET-CT, which was positive for linitis plastica, and affordability was low. So I said I will not do it because the sampling error is there, so I have to send her to another center. So those type of indications, bite-on-bite biopsy, as you're talking about, is mucosal elevations, is only indication is linitis plastica, because if you take the mucosal biopsies, 80% comes negative, and the EUS FNAs are not very sensitive. In those scenarios, what I tend to do is you always take a bigger biopsy forceps from Boston, you multiple bites to dip it, and then you dip the biopsies into deep in, especially in the stomach, not in the esophagus.
Alternative is you can snare out the mucosa and take a biopsy of submucosa for a sampling in linitis plastica.
So he's only asking about surveillance from that point of view, is that right?
Yes.
Yeah. So then that point of view, if he already got a diagnosis, what he's looking for is an endoscopic recurrence. He's not asking for anything else. I'm sure these patients are due for some sort of radical surgery.
Yes, if they have any regrowth, yes, that is what the trial did.